a geriatric injury, who's going to give us a case presentation to start us off.
Okay, yeah, so this, we'll talk about an 81-year-old patient who was brought in by ambulance presenting with neck pain after a ground level fall in the setting of some dizziness when leaving a restaurant with her girlfriends. This was right in late February, right before the shutdowns. She had some loss of, oh, looks like it restarted. She had some loss of consciousness, unclear about any head strike, no antecedent chest pain. She'd been having dizzy spells for months. But she was really otherwise healthy, per report. Was only taking amlodipine for some hypertension, lives here in the city with her husband and son, and no bad habits. On her presentation, her heart rate was, was 79. Her blood pressure was a little hypertensive. Her primary survey was unremarkable. And in terms of her secondary survey, her head, chest, abdominal exam was normal. Her extremities had no evidence of extremity injury. In terms of her cervical spine, she was in a collar, but on examination, she had, C-spine tenderness when she was log-rolled, otherwise no injury to her thoracic and lumbar spine. Her exam, she came in, she was motor and sensory intact, full strength in the bilateral uppers and bilateral lowers, no sensory deficits through her upper extremities, her flank and torso, as well as her lower extremity exam. And then for the trauma workup, she got her chest of CTs of her head, her chest, abdomen, pelvis, which didn't have any evidence of acute trauma. But in terms of her cervical spine, so these are her cervical spine images. And right here we have the sagittals. So on the first one is the left side, where we see a dislocation of the C1 facet on C2. Midline, you see some focal kyphosis at C2, C3, with a small little fracture of the top of the C3 end plate. And on the right side, she had a pars fracture of C2. And there's a sort of the sentinel coronal, where we see sort of this parasagittal fracture through the right side, through the left sided aspect of the C2 body. And there's an axial in line with the C2 ring, where we see the anterior and right portion of her C2 vertebral body is sheared off. The CTA had also suggested an injury to her vertebral arteries, and so this MRI was obtained that demonstrated a left-sided vertebral artery dissection. But we also see here that there's disruption through the C2 and C3 disc. And in terms of her clinical course, the only other thing was she had a right bundle branch block without any prior EKGs. And so we took her to the OR the following morning as she was stable overnight. She underwent an awake intubation, and followed that, neuromonitoring leads were attached. We attempted a closed reduction, which was unsuccessful with serial weights up to 40 pounds. At that point, we rotated her with a bed prone with plans for a C1 to C4 posterior spinal instrumentation infusion. She had a traumatic dural tear at the site of the right C2 pars fracture, which we repaired. And going back to the nerve root, and so because I was unable to sort of reduce her with closed means, I needed to shoehorn the C1, C2 facet. And so though I don't typically take the nerve root, we took it to access the facet on the left side. And so we put a Penfield in there, and I believe a small cob, and then tried to shoehorn it, but we had to adjust her head with the Mayfield. And then once we got that reduced, instrumented her from C1 to C4. And then this is her post-op CT. So she's a little extended between C1 and C2, but we were able to get the C2 vertebral body fracture reduced and her aligned again. And she came back, she remained intubated overnight, was transferred to the floor and subsequently discharged. And, at her latest follow-up, 4 months follow-up, interval, she had interval pacemaker placed for a transient third-degree heart block. She had persistent numbness of that from the nerve resection and was intact. And I think the main sort of points from this, from sort of a geriatric standpoint, are sort of twofold. The first is, even with low energy trauma, folks can have a pretty significant injury. And the other big thing is, a lot of times, even in folks who are otherwise healthy, these sort of spine injuries could be a harbinger for for undiagnosed medical problems. And so that wraps this case up.
All right, great. That gets us off to a good start, illustrating some of the challenges in this group of patients. How would you have handled this differently in a younger patient with less medical issues? Any thoughts? Anything?
I think we could have, we may not necessarily have gone down to C4, and I probably would have immobilized them with like a cervical collar, whereas for her, we did not use a cervical collar afterwards, just to minimize any of the effects, because in her age group, she's at, high risk for dysphagia. And so we were trying to do this as quickly as possible, get her up and mobilized. Whereas I tolerate, a little bit more external immobilization in addition to our surgery.
And does your hospital have any kind of specific geriatric gerontologists involved with the trauma patients to help with those issues in the geriatric patients, or are they managed by the regular trauma team? How's that work?
No, so we do have, if people, so they're managed by the trauma team. If it's only a musculoskeletal injury, just as she had, then they would be admitted over the age of 65. They would be admitted to a hospitalist service, and they would be managing the medical problems and coordinating their aftercare.
I think that's evolving around the country, and I think we're getting better, particularly at recognizing that the problems these people have generally are their medical issues, and certainly the ortho and neurosurgeons are not necessarily the ideal people to manage their minute-to-minute issues. So, all right, let's move to the next talk. And this is a really important topic that gives us all quite a bit of challenge. And Amir Abdul-Jabbar is going to talk about maximizing pedicle screw fixation in the impaired bone. We saw a little bit of that in the last technical thing when Neil showed us that, but I'll be interesting to see how we can improve that, because it is a huge problem.